Okay, good evening, everyone, and thank you for coming tonight. My name is Elias Mosialos. I'm a professor of health policy at the Department of Health Policy here at the LSE, and also director of LSE Health. Before we start, a couple of quick things. The fire exit point for this building is outside Pankhurst House. This is a bit far away from here, though. And please, could everyone turn their phones to silent, if possible. Tonight's lecture is part of a special series to celebrate LSE Health's 30th anniversary, our 30th birthday. And I'm very happy to welcome Professor Reinhard Busse. We're very glad he could be here with us to celebrate together with us our 30th anniversary. Reinhard has a long history with LSE Health. In fact, he was our first international fellow. He joined us exactly 30 years ago. And his connection with the center continued for the next 30 years. Together with Joseph Figueras, Martin McKee, thank you, Martin, for joining us today, Susie Lesov, and a few other colleagues, he contributed to the establishment of the European Observatory on Health Systems and Policies, a major knowledge transfer organization, and he's currently leading the Berlin hub of the observatory, but he is also the head of the Health Policy and Management Department at the Technical University in Berlin. He has had a distinguished career. He is one of the most cited scientists in Germany. He has been in charge of the Health Economics Association in Germany, advisor to the Chancellor, the previous one, and also advisor to many ministers of health, not only in Germany, but also in other places. He has written extensively about hospital reforms, probably a classic book on DRGs. For the students, you might have come across his studies on diagnosis-related groups, but also has done extensive research on measuring quality of health care, focused on low-value care, staffing and human resources, financing healthcare, and managing diseases. Has been also very active in the publications field, apart from publishing his own research. He has edited Health Policy, a leading journal, between 2011 and 2022. And he has advised numerous universities, even in Africa. So he has played an important role in establishing a new master's degree in Ghana, and since 2021 has been involved in a German West African center focused on global health and preventing pandemics. And I'm mentioning this because there are not too many academics who care about low and middle income countries. Reinhard has done quite a lot for high-income countries, but he has not forgotten the marginalized world. And he has contributed quite a lot in terms of advancing health policy and health economics in Africa. But beyond all of this, Reinhard is not just a respected colleague. He's a good friend and someone I think very highly of. His clear thinking, his drive to make health systems better, and his willingness to share his knowledge have made a real difference to our field. And he's a man of detail. I have to tell you a story. When he joined us, he came once to my office with a very long list. He had gone around and checked all the restaurants and all the cafeterias, all the prices of everything they were selling at that period, and he had noticed I was going to the most expensive one with the lowest quality. And he questioned me, why are you doing this? Why are you going to this crap cafeteria? It was the LSE cafeteria, the most expensive one. And there is another one very close, just 30 meters away, much cheaper, with a much better coffee quality. So you could understand that this German mentality focused on the detail was very useful in his academic career, measuring everything, every small detail, but focusing on quality at the same time. Tonight, he will be talking about how well does the German health system perform amid current reforms. So a very timely question, given the big changes happening right now in Germany, which is faced with many political challenges, as you know. There's a new government, a coalition of the Christian Democrats with the Social Democrats as a minority partner, but they have an extreme right-wing party which is rising in the polls, and it is likely that they may start governing a few states in the eastern part of the country. So there's also a challenging political environment with the rise of populism. But without further ado, please join me in welcoming Professor Reinhard Busse. And thank you very much, Reinhard.
Elias, yes, thank you for these kind words. It's really exactly 30 years ago, not only at LSE Health was established, but that I was here sharing offices with many of our colleagues whom we still know and whom we work with. This building didn't exist yet, at least it was not part of LSE, but I just walked over the campus and it's really growing from these 30 years. I thought what we do today, and I think Annabelle, was it you who said I had so many detailed slides? I thought I'm also coming to a university. I mean, you are students, or many of you are students, and then you should also, we should go into details, because you need details, as Elias just pointed out, to understand the big picture. And it will be a tour de force. I mean, we're all clever people here. And I have 50 or 55 minutes, which leaves us half an hour for discussion, and I'm sure there will be many. I gave a half the length version of it today at the Health Foundation. Many people from the Department of Health were there, and there was a lively debate. So without further ado, Elias has already said it, I'm not unbiased. I mean, in the last legislative period, I was both a member of the Ministry of Health. Karl Lauterbach appointed Government Commission on Modern and Needs-Based Hospital Care. And within that commission, I was a leading person in drafting the reform proposal for the Health Reform Act, which was interesting for a professor, that basically our reforms were, I mean, they were not in the form of legal text, but they were pretty much transformed one by one from the contents into legal proposals. Not all of them, and especially the big one, which I show you later, was not surviving as well as I had hoped. And then also interesting, the whole government in the Chancellor's office, or our Prime Minister's office, was installing an expert group on health and resilience, which was also interesting, because we were really meeting in the Prime Minister's office, and it was also a great experience. Okay, let's start. The first thing is, and I've already shown, I had this triangle 30 years ago, so it has not come out of fashion, because I've noticed that it is very difficult for people if you try to understand a different health system. Even to understand your own health system, it helps to have some clarity. I did some exercises when people from different countries come together, and they should explain each other's health system. And then the one, and you would tell you what you have heard, your system, you would do the other one, and you have to tell her system to the class, and it's Babylonian chaos. So it helps us to get some structure, and I say the health system is like a triangle. So we have the population, and some of the population will be patients, chronically or only once in a while. We have the providers, and providers is in the big sense here, hospitals, GPs, pharmacies, and so on. Then we have the third-party payers, which are used in modern systems at the population. The patients don't have to pay the providers directly, so we have third-party payers, and we have the collector of resources, and then flying above the triangle is a regulator. In the German system, we have, starting on the lower left-hand side, we have universal coverage, but we have universal coverage divided into two segments. We have the statutory health insurance system covering about 90% of the population, and we have private insurance. But private, for the last 17 years, is also mandatory for these people. So it's a private health insurance arrangement, but it's mandatory for about 10% of the population. Then we have, for the statutory health insurance system, we have the central allocation pool, and people pay a uniform contribution rate. I will come back to that, because it's important to understand that all Germans who are insured in the system get on their monthly income statements, be that from work, be that from their retirement funds. They see how much they are paying for health care, and it's set as a percentage which is uniform for everybody, and then depending in which of the almost 100 sickness funds you're insured with, there's a certain extra percentage, while the people in the private health insurance pay a risk-related premium. All have choice of fund or insurer respectively. We have these two sets of third-party payers. In the social health insurance, sickness funds, they have typically collective contracts with the providers. So it's not that we have tens of thousands of contracts between the sickness funds and the ever more providers, but they have collective contracts. And we have mainly a uniform benefit package, so no matter in which fund you are insured with, you get the same benefits. The providers is for people coming from other countries in the world with both the public and the private system is unusual because the providers cater for both clienteles. So it's not that privately insured people go to private hospitals and publicly insured to public hospitals. We have both public and private hospitals, and they all have contracts with the sickness funds, and they all care also for privately insured, and we have choice. So currently people can, at least in the ambulatory care sector, can go to whatever provider they want. Not only the GPs, but also the specialists. Strictly speaking, to go to hospital requires a referral, but more and more people go directly, and the number of inpatients, there are more inpatients admitted without a referral from ambulatory care than with. And we have in the center, where in many countries the government, the Ministry of Health would be placed, we have a relatively weak Ministry of Health. Even Germans have often difficulties understanding this, that the ministry is relatively weak, not only due to the federalism and the strong influence of the states, to which we come especially when we talk about hospitals, but also the Federal Joint Committee. The Federal Joint Committee is a bit like the Central Committee for the statutory health insurance system. We have people representatives of the providers, of the insurers, and some neutral members and patient representatives, and they decide on many of the details. Just in passing by, for which Germany is also known, that besides the health insurance system and the statutory health insurance system in 1883, is the oldest such a system in the world. Why many say it's a Bismarckian system, because Otto von Bismarck happened to be the chancellor at that time. So then it was expanded, and the last expansion is 30 years ago to long-term care. And Germany also was a trendsetter at that time 30 years ago. Now the long-term care insurance is in similar problems as the social health insurance as well. We come back to that. So we have this 2x2 matrix of payers. We have two types of health insurance payers, the sickness funds and the private health insurance, and we have the same in the long-term care insurance. We have statutory long-term care insurance funds and private health insurance funds. And in the middle, we have the providers. And the providers, as I said, care also in the long-term care area, nursing homes, they care for both clienteles. And I come to that in a second. Another big characteristics besides the 2x2 matrix on the payer side is the division on the provider side. I will have a separate slide in 2 slides further down that hospitals in Germany means inpatient care, while ambulatory care providers, they provide outpatient care. And this has determined many of the reforms, which I will try to briefly summarize today. The first one, and this is the biggest one, is the hospital planning and financing reform. Then a big issue forever has been the sectoral boundary, because if you have 2 clear separate sets of providers, ambulatory providers and inpatient providers, then there's always some in between. For example, when you go to day surgery, is day surgery hospital as part of the hospital care, or is it ambulatory care? And so there are more and more exceptions, but they all fall somewhere in between. Then we have closely related to the hospital care, we have the emergency care area. And we have now on the coalition contract of the current government, which Elias just mentioned, we have the introduction of a primary care system. There is no draft bill yet on the table, so it's more an intention. And as I already said, we have not only the increase in costs for the health sector, but also for long-term care. And we have, which I don't want to say anything about today, this whole digitalization thing. The minister in early 2001, the then minister Ulla Schmidt said, after a scandal about side effects of pharmaceuticals, she said, we will have a health insurance card, and on this card, that time was still chip-based technology, every important thing of a patient will be on there, and especially the actors, the self-regulating actors in the health systems are proud that they have stopped a real sense of digitalization for now 25 years. And we are now moving, but the electronic health record has now been officially started last year, but most people still have an empty electronic health record. And this is 25 years after the minister said that everybody would have one. This is just to try to visualize the sharp division between hospital care and ambulatory care. Almost everywhere in the world, including this country, I try really to make it very easy. A hospital would have an inpatient wing, and the SPs are the specialists working there, and at the same time the specialists also provide outpatient care. While outside the hospital, typically you have the general practitioners. In Germany, the world is very different. A hospital is inpatient oriented. There are very few exceptions, like an outpatient department exists only in university hospitals. And so when you look at the OECD data, which classify this by type of expenditure, German hospitals make 92% of their income from inpatient care. Dutch hospitals by 38%, and the OECD average is about 60%. So on the left-hand side from Germany is only Bulgaria, where the concentration on inpatient care is even higher. But it's not only that we have this division of labor, it's also that they are represented by different associations. So we have the German Hospital Federation vis-a-vis the Federal Association of Physicians. We have the different planning mechanisms, and the hospital capacity are officially planned by the states. De facto, they haven't done really any planning, but only hospital lists. But it's totally unrelated to what is happening in inpatient care, to what is happening in outpatient care. It's not that, let's say, a hospital department of ophthalmology is in any case coordinated with the supply of ophthalmologists in outpatient care. It's totally unrelated. An overarching topic, as I said, besides the ones which I just listed, is money. And we have the official regulation in the law is quite straightforward, that sickness funds collectively can only spend as much as they make, and that there is a fixed, that's the idea, there's a fixed contribution rate. So sickness funds get more money when people get higher wages, because if everybody pays 15% on income, if you make more money, then also sickness funds have more money. If that is not enough, the sickness funds, because they cannot make a deficit, I mean, these are public law institutions, so what they can do is they have to raise beyond the more money which they get from wage increases, they have to increase the contribution rate. And this is problematic because everybody on the paycheck will not only see the euro amount, but also see or read in the newspaper that this is a result of paying a higher percentage. Otherwise, money had been absent almost for the debate over the last 10 years. It's hard to imagine that collectively, no matter from which party the ministers of health were, they simply ignored this rule in the law that expenditure should only increase with income. The German system, and clearly we have, as you should know, different ways of quantifying it. We can do it in absolute terms. This one is here in euro. Often we do it in US dollar and purchasing power parities. This compares Germany to the average of the EU countries. And we are now in 2023, 41% more expensive in absolute terms. And this is the gap to the rest of the European, or to the European average, where Germany is part of it, by the way, has increased. So 2 years previously it was only 28% more. And you see the percentages differ a bit by the various sectors, but pharmaceuticals, which I will not go into today, and inpatient care are areas where it's close to the average gap. There are some other ones like long-term care where it's even larger. Then we can look at the expenditure relative to GDP. In Germany, except that if people like me come with OECD data, nobody cares about it. I mean, health expenditure as a percentage of GDP, if you ask politicians, they wouldn't say, why should I compare that to GDP? It is high, as we see. These are OECD countries. We are now in number 2 after the US, and I dotted here the UK. And it has not only increased over time, but it has increased faster than the OECD average. So you might say it's not big, but 20 years ago, the percentage point different, we were 2.2% more expensive. Now we are 3 percentage points above the OECD average. But as I said, German politicians, and this is I think this is the only German language slide which I show. They look at the contribution rate, and the contribution rate. Maybe we look at the right-hand side here. So there's a fixed contribution rate of 14.6%, and the rest differs from sickness fund to sickness fund, but you can calculate the average across all 100 sickness funds. And you see when you look carefully between 24 and 25, this black thing has increased from 1.7 to 2.5. So there will this 0.8% of gross income is the largest increase ever. So in no single year in history have the health insurance contributions increased as much. The minister had promised still in November that this would not happen again, but early this year again the health insurance contributions have gone up. And when you look at this over time here, then the contribution rate since 2005, so over the last 20 years, has increased by 3 percentage points. When we hear expenditure, then there are 2 possibilities. We do too much, or we do a lot. So it's the quantities, or the volume, or it's the price per unit. And for Germany, the answer is totally easy. It's the volume. And this one compares. Many people don't really look at this figure in the OECD held at the glance. OECD, this is an estimate, but it gives a pretty good approximation. So our prices per unit are at 76% of the OECD level, while the volumes are at 140% of the OECD level, which is problematic. I mean, when you calculate, you see that we are more expensive than the average. But it also explains, well, if you ask an individual provider, be it a hospital, be it an ambulatory care physician, how much they make, they all say we get too little. When I talk to my colleagues in other countries, they all get more money. Yes, or in many countries they do get more money. For example, they would get more money if they provide the same service here in this country. But expenditure is volume times unit cost, and this is where our problem starts. You can calculate that this one is placing EU countries vis-a-vis the European average, both in terms of the hospitalization, the inpatient treatments per population. EU average is a few years old, but the trend is still valid. 170. Germany at that time was about at 250. So 50% more inpatient stays per 1,000 population. And it's not that we treat people in hospital and not in ambulatory care. In ambulatory care, it's also much more than the European average. So the volume issue, first of all, there's no trade-off between inpatient and outpatient care, and secondly, it affects both areas. You can take a broader view beyond healthcare. And when the previous government started, so 2021, not the current one, the Federal Statistical Office in nominal terms calculated public expenditure in total over the 30 years since unification, and also by sector. So total expenditure went up by 150%, as I said, in nominal terms. Health was by far the winner with 245% increase. And you see the other ones. So the health increase is 7 times as pronounced as the increase for defense, and even 16 times as much as for housing things. So the health people were very successful, and they still go. And this is just shifting now the debate. Hospitals will go around and say, we need more money, more money, more money, more money. And then when we see huge increases, because the politicians were, at least in the past, gave in and gave them more money. Then you can say, okay, you give them a lot of money. What do you get for it? And this will be a health system performance assessment exercise in 10 minutes. It all started. You were still very young. Even I was, and Elias were still quite young at that time, the year 2000, with the World Health Report, Health Systems Improving Performance. And it provided a good framework, which I show on the next slide, but it also ranked health systems by their performance according to the important dimensions, so health, responsiveness, fairness, and financial contribution, and put this in relationship to the expenditure. And the German system was only ranked number 25. Okay, much higher than the US system, but much lower than the French one. And 25, I mean, our politicians were totally quick and saying, if WHO ranks us number 25, and we have the best system in the world, the exercise is wrong. So it's a clear solution. So performance assessment must be a bad thing. The idea there was actually, I mean, I think for the first time, WHO really presented what do we expect from a health system. So the inputs, or what they call the functions and the objectives, were behind it, and you would measure the results on the right-hand side, which was, at least from the graph, absent, but in the table present was the efficiency dimension. But otherwise, these were the 3 objectives. It was in the following years a bit further modified, because politicians were also asking worldwide, where are the buzzwords such as access and quality, where were they in this original framework? So they were added as intermediate goals, and this then was called the health system framework, health system building blocks framework. A few years ago, the German Ministry of Health asked my department to rediscover basically health system performance assessment, because on the European level there are now many activities in several countries in coming back to looking at health system performance assessment. And we also wanted one, and they commissioned us to look at what other countries are doing, come up with a framework, and then to do 2 pilot reports. And our framework is based on the previous one. We say, okay, if you think about a health system, what do people expect? They expect access or accessibility. And for those people who have access, this is why I multiply it, we then talk about the quality. Many people have a broader understanding of quality and mix it up with performance. So the whole thing is performance, how well a system performs in the various dimensions, while quality is one of the performance dimensions. And if people have access and the quality they receive is good, then we should see that both in the contribution of the health system to population health as in responsiveness. Sometimes this is part of the quality dimension called patient-centeredness. WHO called it responsiveness, which makes more sense. If you then divide this by either the inputs, so how much money, how many euro do we spend in it, or the outputs, how many hospital spells do we have, how many patient physician contacts, you then get the system-wide efficiency. So how much health do we produce for the euro spent? If you only put outputs in relationship to input, you get the technical efficiency. Technical efficiency in the German system, as we will see, is different than the system-wide efficiency, the cost-effectiveness notion. We produced these two pilot reports. The last one was published two years ago, and these are all the indicators. So they are the performance dimensions that are just shown: access, quality, population health, responsiveness, efficiency. And then there are some other ones which are also important. And we rated them, and this is clear for policymakers, color coding. The greenish, dark green or light green, means Germany is doing either better than comparison countries, and we agreed with the ministries to compare Germany with 8 countries, mainly the neighbors: Denmark, Netherlands, Belgium, France, Switzerland, Austria, and we added in UK and Sweden. The ministry didn't want us to compare ourselves with the southern European countries. So green means better than the other countries or a positive development. Dark green is both, light green is one of them. Yellow and orange, Germany is somewhere in between, and red, it's a poor performer longitudinally and compared to other countries. And this one is really a very short version. We'll show you some slides in a second. But we see access is only green. So we have good access. Quality is mixed, everything from green to red. Population health is below average. It's red or yellow with one exception. Responsiveness is equally mixed. And efficiency, the first two red ones are the system-wide efficiency, which is poor. The other ones are technical efficiencies, which is okay. It's between green and orange. Just to give you a glimpse, what we did, for example, this is access. We looked at both the density of providers, but we also calculated for every German how much a travel time would be to the nearest general practitioner, to the nearest pediatrician, and to the nearest emergency department. And maybe you cannot read the colors there. Everything in green is less than 15 minutes. So even for pediatricians, there are very few areas, and these are sparsely populated, where the access time would be more than 15 minutes. And when you look at emergency departments, clearly this is the good, in inverted comma, side of having an oversupply of hospitals. There's a hospital everywhere. You don't have to drive even in rural areas, typically more than 20 minutes, and then there's a hospital. A major patient-relevant indicator of ambulatory care quality, at least that's how it is seen worldwide, is not being hospitalized in case of chronic conditions, or what we call avoidable hospital admissions. We see here two examples: chronic heart failure on the left-hand side and hypertension on the right-hand side. Maybe we only look at hypertension. It's difficult. I'm a medic, to understand what are people as a main diagnosis, or the reason why they are hospital, with the main diagnosis of hypertension do as inpatients. And the lowest line there, together with the light green Netherlands, is the UK there. You could say Germany has improved. It's no longer 15 times as many as in the UK, but only 10 times as many people with the main diagnosis of hypertension. And similar with chronic heart failure, the differences not only to the UK but to other European countries are really huge. Let's move to the quality side. As I said, the mixed picture. This is one of the red examples where we have the number of inpatient cases who died during hospitalization. Germany is a thick red line there, so we have a case fatality of about 8%, and this is 2 times higher than some other countries, and if anything, then the gap has even increased. And yes, within Germany there's huge variation, so these are averages, which doesn't mean that when you go to any hospital you can expect it, but averages are averages of what you can expect in the country. So big problems here. And then we came to we used then clearly when you say, okay, how did they measure the contribution of the health system to population health? And we looked out of the spectrum of avoidable mortality, we used the subset of treatable mortality, because when you go to hospital, or let's say the areas where we spend most money, drugs, hospitalizations, is treatable mortality and not preventable mortality. And we did this longitudinally, because if you only do it cross-sectionally, you can debate that there are many other factors also having an influence on these causes of death. If you do it longitudinally and only look at the change, then many of these discussion points are gone, because then the change you can more accurately attribute to the health system itself. So when we do this for Germany, and the 10 points here are the points from 2011 to 2020, the avoidable mortality decreased. So the contribution to population health improved. There are fewer people dying due to treatable causes. But when we do the same thing for other countries, we see that other countries typically have larger decreases. And Switzerland has the same decrease over these 10 years, but at a much lower level. So they already had, at the beginning of that decade, much lower rates than Germany had at the end, and they still improved. Netherlands, big improvement. Denmark, even larger improvement. And then you see this thing is two-dimensional. So on the other axis, we plotted the increase of the health expenditure, and again looked at the increase. So the longer the era, the more money extra, incremental view we used on the system. And when we compare Germany to Denmark, it's especially telling. Denmark increased its expenditure by about half as much as Germany did during these 10 years, and it decreased the reduction in avoidable or treatable mortality by at least twice as much. So the efficiency over this 10-year period is much better in Denmark than in Germany. We had a previous version of that a few years ago when we had the article on the German health system in the Lancet. We used also some non-European countries, or the one, because the Lancet editors wanted us. So we took the US, and the US is even much further up right. So the German system is much better than the American system, but within the comparator group here, you see it's the furthest northeast, so it has the highest expenditure for the outcomes. And with that, I think the situation should be clear. I mean, the hospital reform had a clear mandate, and one mandate is clearly the overprovision. And politicians often ask me, how do you know it's overprovision? I say, yeah, I have looked at. You cannot look and only retrospectively at at each of the 17 million inpatient cases. But we have some indicators, and one is international comparison. This one is post-pandemic here, 2023. So the rate of inpatient hospitalization has gone down. The previous graph showed you around 250 per 1,000 population. Now it's about at 200. But we still have only Bulgaria ahead of us. So if number of hospitalizations would be a quality indicator, then Bulgaria would have the best health system in the OECD group. And you can look from the German perspective, so this one compares Germany to the other countries to Germany. And Switzerland, for example, is in many cases similar to Germany. Similar tradition, similar payment system, and even they have 25% fewer inpatient cases. Denmark has 40% fewer inpatient cases. The UK has 50% fewer inpatient cases. The Netherlands have 60% fewer inpatient cases. 60% means we have 2.5 times as many hospitalizations as the Netherlands. So we are not talking about a few thousand or 100,000. So we have 17 million. If we were the Netherlands, we had 8 million or 7.5 million cases, which would require a totally different hospital in infrastructure. If you go to intensive care, this is from one of our projects, it's even larger. The differences are even larger. In Germany, we put, you see 1 in 11 there for Germany, we put 1 in 11 patients who are admitted out of these many patients on intensive care. So we have 2 million intensive care patients a year, and so it's a lot. It's when you compare it to Italy, and again you can argue, do they have too little in intensive care in Italy? But it's factor 6, so it's really huge. And I also like this graph, which compares the Danish hospitals locations with the German hospital location, and just when you look at it, you get the idea. So we not only have a high number of inpatient cases, but also in terms of hospital numbers, hospital beds. Obviously, you can debate the chicken and egg question. Do we have so many beds because we have so many ill people, or do we have so many people which we put in bed because we have so many beds? And the pandemic, in a sense, told us we paid hospitals for empty beds, and we got a huge decline. I know there were declines in other countries as well, but in Germany we had a very pronounced decline in the number of cases, and it's stable since then. In the pandemic, we paid hospitals for empty beds. Since then, this explains a major factor why hospitals are doing badly financially. They still have the pre-pandemic bed levels and are expecting case numbers and DRGs attached to the case numbers, which make up their costs, and this is now gone. I said already, the states are responsible for the planning, but it's intransparent and unstructured. And one of the other problems is that we have no notion of a general hospital. A middle-sized city, let's say 150,000 inhabitants, would have 3 hospitals, one public, one private, one church-owned, let's say. And you say, yeah, but where do I go if I have any problem? People would say, yeah, if you have a stroke, you go to hospital A. If you have myocardial infarction, you go to hospital B. And if you want to give birth, you go to hospital C. I mean, which is a totally irrational system, and especially that many people don't exactly know which diagnosis they have, and they might go to the wrong to the wrong hospital. And even the wrong hospital, so the one not specialized in strokes because it has a stroke unit, the other ones are still allowed to treat stroke patients. So we see that stroke patients are treated in hospitals without a stroke unit. Even the one with stroke unit would be down the road. The same with angiography units and acute myocardial infarction. And really unbelievable, we have more than 400 hospitals which are certified cancer, or which have certified cancer centers for certain types of cancer, often multiple ones, but 400 hospitals have any type of cancer center. 50% of cancer patients are treated in the other 1,300 hospitals which don't have a cancer center. Staff has increased. Many politicians haven't recognized that really. It's partly by political influence. For example, in 2020, has nothing to do with the pandemic because it was decided beforehand. we had said to the hospitals, okay, we have a nursing shortage. Obviously, by the way, we don't have a nursing shortage. It's only we dilute our nurses to the many patients which would not be hospitalized in other countries. So we said, okay, if you spend money on nurses and know how many nurses you employ and how much you pay for them, we give you the money directly back, which was a big push, obviously, for nurse employment. And we also spent a lot of money. This one looks, and we maybe only look on the left-hand side in relative terms to GDP. We used in 2010, spent 3% of GDP for inpatient care, which was already a lot, but less, for example, than in Denmark or in France or in Austria. Then 10 years later, or a bit over 10 years later, it has increased, while Denmark is an interesting case. Many people say, yeah, but they have invested so much money in their hospital reform. I say, yeah, they have invested over 10 years the amount they spend every year on providing hospital care, so 3% of their GDP. But afterwards, they pay less to the hospital. So this is true investment costs, while our hospitals want investment costs to get more running costs in the future. So this six years ago, no, we did this in the very first year. So in 22, together in the spring 22, we came together. We were appointed by the minister, and already at the end of the first year, in December 22, we presented this draft proposal to reform the hospital sector. It was already difficult in the discussion, because we said actually the main problem is this unstructured planning, and that every hospital can do whatever they want. And the minister said, yeah, but you need to be careful, because it's the state authority to plan hospital care, so please concentrate on the things we can do. And I said, yeah, but if you cannot plan, then it's very difficult to only change it by financing aspects, for example. And we came up with a triple jump here. So number one, hospitals are placed on 3 levels, defined, for example, by the physician availability out of hours. Currently, hospitals function without specialists at night. I mean, most people and most politicians don't know that the junior doctors are there, and that the senior doctors have 30 minutes to come to hospital. So they're not sleeping on the hospital campus, they sleep at home. And a very important instrument to check that for our medical review board is Google Maps. They check where the physicians actually live and whether they have any chance in making it to the hospital. And we said we need to soften the strict sectoral boundary between inpatient and outpatient care by transforming many hospitals into so-called integrated care centers. Second aspect, services. If hospital things are planned, they are typically planned by departments or specialties. And nobody says whether a hospital can do spine surgery. And spine surgery is booming, mainly in small hospitals, but by different specialties. Sometimes it's orthopedics, sometimes it's neurosurgery. So the states in their planning of departments don't interfere in any case what the hospitals are doing. They're not only not demanding a stroke unit for treating strokes. They say, okay, what your orthopedics are doing, we don't care. So we said we regroup the planning units into so-called service groups requiring similar personnel and technological equipment. And last but not least, the third component, the financing, that we would reduce the DRG component in favor of budgets or budget type instrument per each of these 128 service groups. So we had this nice graph. It's actually my PowerPoint skills. That's why it is a bit bent there, which was in the final report. So we said we need a clear structure, and the main thing is that we have something like a general hospital, so that we have this intermediate level where and we were yelled at. I said the general hospital should be able to provide care for stroke patients, AMI patients, and for pregnant women. I said, how can you demand that a hospital which is treating stroke patients also is able to give birth? I said, yeah, because these are common things, and people expect that a general hospital is doing these things. Then the green level there, the level 1 was divided into those with an emergency unit, hospitals which are further away than 30 minutes driving time from the level 2 or 3, and the rest would be transformed into integrated care centers. We published this, as I said, in December. The minister fully endorsed it. Over Christmas, many said, yeah, we really need hospital reform. Beginning of January, they came together. Let's say trilateral was the federal ministry, the federal parliament groups, and the states, and said, how can you, federal level, tell us in Bavaria how to plan our hospitals? I mean, Bavarian hospitals are totally different than the ones in North Rhine-Westphalia, as we all know, so there can be no uniform regulation. The next one was the 128 service groups, which I show on the next slide. We would also say you need a certain hospital-wide level of technology. So when you do spine surgery, it's not enough to have somebody who says, I'm experienced in spine surgery in a village hospital. It's also important that you might have a radiologist or an intensive care unit or pathologist or a surrounding. So you cannot do that in a level 1 hospital. You would need to be at least a level 2 hospital. So these are examples here. Basic general internal medicine would be allowed for every hospital. Hematology and oncology only from level 2 onwards, and let's say stem cell transplantation from level 3 onwards. Same with the surgic examples here. In the negotiations, well, the levels were gone, so the tying of the levels was gone, and they said to 128 service groups. It is much more detailed, and by the way, North Rhine-Westphalia is just not a CDU-governed country to whom I feel responsible. A few years earlier, I had sold this concept of service groups to the North Rhine-Westphalian government. They had picked it up, but reduced the number of service groups from our proposal to 61 in North Rhine-Westphalia. And so the state said, service groups are okay, but only the ones which we already introduced in North Rhine-Westphalia, which, as you know, is the largest state, which then means that many of the service groups now are very close to the original departments again. The very specialized services are outside, but all the other ones are back, like general internal medicine now includes acute myocardial infarction and those types of cancer which don't have their own service group, because the service group oncology has been wiped out of the proposal, similar in general surgery. So a colon cancer is now a surgical case because the primary treatment is surgery, and so colon cancer has nothing to do with oncology, but only with surgery, which is, if you have a medical background, not fully understandable. The third one was, as I said, was the reorganization of the payment. And since 2020, 20% or roughly 20%. It's increasing because they hire so many new nurses. So on average, it's about 20%. Now maybe 22% is paid for nursing, and we would say so the 80% which are paid through DRGs should be reduced. We said 60%, and the remainder of 20% should be used for budgets per one of these service groups. This one was totally popular in the negotiations. They said, we like it, get rid of the DRGs, so why not cut them down to 40% and make the budgets even larger. So that one passed. What happened, as I said, the trilateral negotiations started in January. States' reaction was officially positive, but then soon they put one hurdle after the other in the way. Karl Lauterbach, as a minister, got a bit impatient over the course of the debate, added a second law next to it, which would improve the transparency. And he said, but in this law, we will sort the hospitals by levels, even if you don't plan by levels. And legislation is finally enforced since December 24, but with the long transition, and many of the deadlines have already been passed, and the states haven't reacted. Partly, or again the hen and the egg problem, partly because the new minister has said we will do a revision of the Hospital Reform Act, and that will give you more exceptions and postpone the transition period, I think now to 2031. Possibly or probably the sickness funds are bankrupt before the hospital reform will see the daylight. Intersectoral care, a wide topic. So the reduction of inpatient care in favor of outpatient care challenges all rules of the German healthcare system game. I've already said about that. This is a totally big challenge. I remember already 15 years ago I went to an internal meeting of the Federal Association of Physicians, so the ones representing the ambulatory care provider, and I would say if I were a politician I would abolish the German Hospital Federation and your association and merge them into one association of healthcare providers. That would probably get rid of many of the problems. Emergency care. Emergency care is partly homemade. For example, ambulance cars, when you call the 112, the emergency number, and they pick you up, they only get paid if they take you to hospital. Even if they know you are not ill, you are not requiring hospital care. If they leave you at home, they are not paid. So what are ambulance cars doing? Of course they take you to hospital. I mean, they would be stupid if they don't. And the main issue is once people are, and this is a red box here, so we have as many emergencies roughly as in other countries. I'm aware we have about 35 emergencies per 100 population in a year, so 29 million. We have the physician associated number and the hospitals. The hospitals see about 21 million people in their emergency rooms. And the unusual thing in Germany is that they used to keep 50% or almost 50%, put them in bed. It has gone down a bit, but all other countries I know, the conversion rate basically from emergency rooms to bed is much lower. Denmark is about 20%. For us it's 40%. So if we had the same number of people showing up in the emergency rooms, but if we put only as many into bed as in Denmark, that would halve our inpatients admitted through emergencies. So we have a big problem there. The main problem is that we have so many hospital emergency rooms and people find it very close to go there. So the idea, and this has been on the agenda for ages again. There was 2 legislative periods ago on the agenda. Last legislative period, it was in Parliament, it was in the Health Committee the very day when the coalition government broke down. There was no opposition. It would have totally passed, but then it was with the end of the legislative period, it was gone away. So the idea is that similar to other countries, you would link the different telephone numbers for the 112 and the outpatient emergency service, and that even the people who would approach a hospital would be channeled through an integrated emergency center, which would again separate those people worth of seeing by the hospital, and where the danger is that the hospital puts them in bed, and those who go into the outpatient managed physician practice on site. There is again a draft proposal on the table now from the current minister. Whether it will pass this year, I don't know. Primary care, I already said, the coalition has promised to reform primary care. I'm skeptical whether people will really, whether in the end they have the guts to really pass this law. And this leaves us with long-term care. Long-term care has, in the 30 years, many things have happened. There's a broader definition of long-term care to include people with dementia. There are increasing benefits, for example, for carers. There are increasing prices, often due to the fact that we want to have more nurses and especially better paid nurses in nursing homes. And the overall effect, no wonder, is that expenditure is going up. I mean, you tell more people you are qualified, you say you get more benefits, and we pay the benefits better, and then politicians wonder why the money is getting scarce for long-term care insurance. I'm not so there's also a commission who is charged with looking into this. So it's a homemade issue. Well, and after this tour de force, I thought I need at least one slide to attempt to conclude it. They actually have become two slides now. So the German health system, I think, if we had known that, I hope I have convinced you, with its long history, is embedded in more traditions, ambulatory inpatient separation, federalism, self-regulation than those in other countries, making it very hard to reform any aspect, let alone the entire system. No government has ever promised or even secretly tried to reform the whole health system. Many actors also lack an openness. Whether it's really not understanding or whether they pretend they don't understand is often unclear. For acknowledging main facts, for example, overprovision, inefficiency, bad value for money, and willingness to learn from other systems, from other countries. The topic now is addressing the ever-increasing deficit or the increasing contribution rates, for which an expert commission is charged to make proposals until the end of March. It's all secret, obviously, but they told me yesterday they need to create savings of 30 billion euro only for next year. So it's a big issue, and that has brought many of the issues back on the table. I mean, if we compare the publicly covered paid services by sector to the other EU countries cover most of hospital care, but only 91%. We cover 97%. Outpatient medical care, 93 to 77. So we are more inclusive, more generous, and all that comes on the table now. They are the first politicians to say, why are we covering dental care? Why are we not kicking out dental care out of the benefit basket? Then there is, for the first time, growing support for people who say, let's increase taxes on tobacco and alcohol to avoid these things. So we need more money, and this will be the issue for this year. Not everybody has noticed the seriousness of the situation, but it's the recognition is growing. Thank you for your attention. Back to you, Elias.
Oh, thank you so much, Reinhard, for this fascinating lecture. So my first conclusion is that if you ever visit Germany and you cannot find a hotel room, you can go to a hospital. You will definitely find it. But this may come at a risk. They may perform spine surgery on you.
Yes, yes, very well summarized.
So,
and you can, if you don't know where the next hospital is, call 112 and they will bring you there.
Absolutely, yeah. So we have time for questions. If you're asking a question, please say who you are and where you're from first, and who would like to start? Any volunteers asking questions? Yes,
there.
Please. Oh, one there, and then we'll. Yeah.
You're a Special European Observatory on Health Systems and Policies. Thanks so much for this very inspiring lecture. There was one thing which you haven't really touched on, but which I think is quite important for healthcare infrastructure, healthcare utilization. and which is a little bit difficult to adjust for, but that's the population structure, the age structure of the population, which we know is, Germany has an older population than, for example, the UK, so it's a little bit, it has to be kept in mind, so or it has to be somehow, we haven't managed so far to sort of figure this factor in, but I think we haven't really talked about that, so I would be interested to hear your thoughts on that one.
Okay, I try to make it brief. I mean, within Germany, it's always the excuse. I mean, if politicians don't know anything about method, they have somehow picked up the idea of risk adjustment and so on. Then they always say, yeah, but you need to risk adjust. You need to take this into account. Then I say, I tell you a secret. In other countries, for example, Italy, the population is also aging, and actually the inpatient utilization is going down. So we don't have to accept that this is simply happening, and that if we have more old people, that we get more utilization. I mean, our ambulatory care practices, the second last minister, Jens Spahn, prolonged the opening hours from 20 hours per week to 25 hours. And I say, yeah, but a week has 168 hours, so even if they are open for 25 hours, what happens in the other 143 hours? So that people then turn to hospitals, and if they go to hospital, and that is a very important factor, I said, we don't have specialists there, so most junior doctors, if it is 3 o'clock at night, they don't call their supervisor. They rather put the patient in bed, and when the patient is in bed, he or she will stay there. So, yes, I mean, we have to think of the future and say, okay, what type of healthcare do we need when the population is aging? But that doesn't mean that we say, oh, there will be so many more hospital cases in future. The latest trick now is emergency preparedness. If Russia attacks us, we need all the hospitals for our wounded soldiers, so we cannot close them. This is now the latest argument by the Hospital Federation.
Interesting argument. More questions, please. Yeah, over there.
Yes. Hi, I'm Jill. I'm from the Department of Public Policy at LSE. And I was just wondering, what do you think is it a good approach to cut the services down, or will it drive more like patients to go to private insurance, especially the ones that are like young and healthy and think, okay, I don't get the service that I want anymore, probably the ones that I just go to private.
Well, I'm totally long in this field. I was among the first ones when we developed health technology assessment. And the idea of the politician at that time was that you can identify the good services which are effective for most people, they thought, and there are other ones which are ineffective for everybody. I think we know by now that many services are good, effective, cost-effective for certain people and for other people not. So I'm not a fan to say we drastically cut totally types of services like dental care. We rather, when we see we have the overprovision, and overprovision, let's say, come back to inpatient care, does not mean we can say we are no longer paying for certain surgeries and keep the other ones in. We really need to identify what we would call low-value care. So who are the people who can really benefit from the services, who cannot benefit? And really important is to cut capacities. I mean, if you have overcapacities, hospitals will put somebody in bed, even if we incentivize them not to do it. And that is maybe the strange thing for me, that many people do not make the connection yet between the hospital reform and the financing. I mean, the states are still saying we need more money for the hospital reform, and at the same time they're all saying, oh, we run out of money. And the bad solution would be to keep all the small bad hospitals and cut the dental care coverage. I mean, that would really be a very bad solution. There's somebody over there.
Yeah, of course.
Thank you. I'm Robert Yates, a visiting professor of practice at the LSE. Given this very high utilisation rate and your financial problems, do you have co-payments in the German health system? And are there sort of moves to increase those to reduce demand?
Well, yes, there are, but there are, I mean, in outpatient care, there are none. For hospital care, there are minimal 10 euro per day for up to 28 days, and they haven't been adjusted for more than 20 years, so they not even by inflation. Some people say we should at least adjust them by inflation. The same with co-payments for drugs. They haven't been nominally touched for more than 20 years. But we also all know the problems with that. I mean that you have to really steer appropriate usage if they help. And I would say they help if you have a good system of exemptions. For example, for chronically ill, you say you are exempted if you take part in a disease management program, and if you don't, you pay a co-payment. So it's not as easy as some of the politicians who now propose it think it is.
More questions? Yes, we have one there and one there. First, the gentleman.
I'm Denny, I work for the Department of Health. I just want to ask, you mentioned tobacco taxes. Could you talk a bit more about whether the push to decrease contribution rates has led to discussions about wider sort of prevention and implementation of health measures?
Well, first of all, there's no push to lower contribution rates. I mean, it's really a push to keep them constant. And we now see that, I mean, we have to remember if healthcare would be the only sector paid by social insurance, we would probably be more relaxed. But beside health and long-term care, we have unemployment, we have pensions. So there are many pillars of social insurance, and employers count everything together. And the employer organizations now really say, government, we really have a problem. You and the previous governments have always said that the total percentage should not go above 40%. Now it's 43 or something, and it's increasing. In previous times, there was often the solution that we put in more tax money to soften the contribution rates. The biggest sector where this happened is pension. Like the pension system relies no longer only on the pension insurance, but also to tax subsidies. We now have realized that it is a zero-sum game. I mean, if you want to save people's social insurance contribution and raise taxes, it also cuts a hole in the public budget. So we have realized that this is so that the tax subsidies are also not the solution. Now, turning to your question with the prevention, among the many proposals like cutting dental care, increasing cost sharing, is now also regaining popularity to increase tobacco charges, alcohol charges, which was for a long time. I mean, cigarette prices have also increased, but not as visible as in many other countries. Marketing is still more pronounced than in many other countries, especially for alcohol. But this is now coming on the table, whether we shouldn't use this also as a source of income. I wouldn't say that this is a big recognition that we need more prevention, but it could be the side effect that we also put more emphasis on that.
Tobias Liege, I'm from Munich and I study here. To the emergency care reform, what's in your opinion, or what are in your opinion the key goals of emergency care reform, and how well does the current draft address them?
Well, I mean, the drafts they have several components. For example, one is that ambulance cars they would be moved up to a ladder where they are no longer transportation, So currently they are not considered a service, it's only a transport to hospitals. So they would become a service entity themselves, and if they provide care for the people on the spot and they don't need to be transported, they could also be paid for it. So it starts relatively early in the chain, then the tying together of the different systems. But the most important system is this integrated care. Here there's integrated emergency centers, and that most people agree, but the proof in the pudding will be how many hospitals will have such integrated care emergency centers, because already the hospital thing, probably there will be fewer than we now have hospital emergency rooms, and they have already opened a new front, and they say, yeah, but if you don't have an integrated emergency center, you can still have an emergency room. And you see then the system would be bypassed. So the thing is not the political agreement, it's then the implementation. And the implementation there is even more complicated than for hospitals, because for the emergency care, the road-bound emergency care units is not the health system responsible, but it's tied to the firefighters. So it's the Ministry of the Interior, so it's even within all the 16 state governments, you already have 2 ministries involved in the planning. So I'm not totally optimistic that this will be a fast reform.
Are you optimistic about anything, sir?
No, I think the money will now be a real problem, and when the employers are putting the finger in the wound, and they say, I mean, we are not only hurt by tariffs issued by Trump, we also hurt if the BMW we want to sell in the US is not only having the tariffs but also the high social insurance contributions on it, and the government has to do something about it. It will be tough, the debate, cutting the benefit basket and so on, but this will happen. Whether the government agrees or whether then again the contribution rates will go up and we have general elections, and we have state elections basically all the time, and so even the federal government, even if it doesn't face direct elections, they face indirect elections basically, and so it is very difficult. I agree for the politicians, for example, hospital reform. When they close small hospitals, people will maybe turn to the right parties. If they keep them open and the system goes bankrupt, they will also turn to the right party. So it is difficult to be optimistic, but something has to happen.
And if I ask you, who are the main veto players, those who are more likely to block the reforms? Are they the state governments, hospitals, doctor associations, big pharma, private insurers?
Okay, let's start with maybe interestingly the whole private sector. We had a question at my lunchtime presentation on that. I said the big debate we also had among scientists and people like us, whether we shouldn't merge the two systems, like in the Netherlands. It's totally not on the table. So the whole private health insurance system is out of the debate. They will be, in the second step, they will take over many of the regulations from the statutory system, but it's not that they are a driver nor an opponent. They can keep quiet. Pharma has this double role. I mean, it's the same as here, that you try to make industrial policy on the account of the health, on the health budget. So they have been saved cuts by now, but when you look at the comparison to other EU countries, we see that the gap is biggest for pharmaceutical spending. So something will happen there. They will then appear when it's their turn. The state governments really have the most dubious role. I mean, they all think they They benefit if they can keep their small hospitals alive, because they say, we are not paying for the hospitals, the sickness funds are paying for the hospitals. So if I have a hospital more, I probably attract more money from other states to my state. But if they all think the same, it doesn't work. I mean, and they haven't made the connection yet between the social health insurance financing and them demanding more money for the hospitals. For example, to prevent an increase in the contribution rate, there was a last-minute harikiri action by our minister. She wanted to cut expenditure by 2%, and one part of 1.8 billion of that were from the hospitals, who would not even have seen a cut. It was only about the increase. So whether their increase would have been by 1.8 billion larger than without this cut, and the state ministries prevented that, which then in return, because they prevented that in December or late November to December, the sickness funds all had to make their calculations for the upcoming year, meaning 26. They said, okay, the parliament, the two sides of the parliament haven't passed this cost cut, so we need to increase the contribution rate, and it went up again. And this is what is now really alarming, that the state governments in the Federal Council, where they all vote, that they risk increasing the sickness fund contribution rates to get more money for their hospitals. And then we are really that means we are really in bad trouble.
But who wants to reform the system then? Apart from the academics want this. Is there anybody who wants to reform it? So.
I think it's not hurting enough yet.
Okay, yeah. And related to this, Reinhard referred to Karl Lauterbach. Karl is an eminent professor of health policy and health economics. He got into politics with the Social Democrats. He was the Minister of Health until a few months ago, for many years, in fact, more than 5 years, during the pandemic.
3 years.
3 years? Okay.
He was very visible during the pandemic, but he was not minister then.
Okay. I got it wrong. So, but 3 years is enough for an academic to be in the Ministry of Health. So, did it make a difference that you had an eminent counterpart in the Ministry of Health? Did it play any role to have an academic leading the Ministry of Health or not?
Well, I mean, Karl he's a colleague, basically, and he's also a special character. I mean, I think all of us, we would say that none of us, even we none of us knows everything.
Of course.
And if you think you know everything, it gets difficult. So he would have been even better advised to take more people around him. I mean, he still did that partly. So I remember, during our meetings from the commission, he often participated. So we had more direct access to him, but in the public opinion, he often went to talk shows and in television and made announcements there which were not coordinated with his ministry, for example. So yes, he was a special minister. He was more on the evidence side, but that came to at a certain price.
Okay, understood. So probably you're going to be discouraged in terms of getting involved in politics. You have a question here? Yeah. Another on there. Yeah.
Hi, my name is Jasmine Powell. I'm a Canadian public health physician. Thank you for the presentation and the detail. It's appreciated. There's a lot of complexity to these pieces. I'm interested in the interest and influence around hospital federations and medical associations. And I was curious to ask if there's any European countries that you feel those interests were especially entrenched and a bit of a challenge to reform that was then overcome, and which countries, and were there any creative strategies in addressing that?
I was recently at a policy dialogue on hospital reform in Vienna, And so the countries represented there were, besides Austria and Germany, were Czech Republic, Slovakia, Hungary, and Slovenia. And this, as we would say, Middle European countries all share a very common history when it comes to hospital care, and also when it comes to the corporatization of the medical profession. So in Austria they have, what they don't have in Austria is, we have this separation. We have the medical association, where, for example, people like me, we are mandatory members. And the physicians association is only representing the ambulatory care people. So they are all part of the medical association. So in Austria, it's similar. The Austrian Medical Association is also representing the ambulatory care for physicians. And they have this pretty similar regulatory setting, that the states are responsible for the hospitals, and they have carefully managed to bring them on board. It's still difficult, but maybe it's also because it's smaller, they all know each other, but I would say they are still not there yet, but they had made more progress. For example, what would be unthinkable for us, that they have a uniform Austrian hospital plan, and in the hospital plan they also have the outpatient units. They list all the big technology in this plan. Our states would say, wait a minute, why should we even give you the data? We are Bavaria, we are not forced to share our data with the other 15 states. So so these Middle European countries all face this common challenges, and they all have very high inpatient utilization rates.
Yeah. The Austrian system is much more complicated than yours, though, so it's not a good example, but please.
Yeah, thank you for a great talk. I'm a resident in internal medicine in Munich, and I was wondering if you have any data on how far the costs are so high because we apply drugs and therapies on elderly people. Is there any data?
Well, 1.5 years ago, with my colleague Christian Karagianidis in intensive care physician from Cologne, we looked at all the ventilated patients in Germany, and also put them on, calculated how large the risk is that you are being ventilated when you go to a German hospital. And when you then compared the rates for the younger population, let's say below 65, is comparable to the rates in other countries. But the older you get, the larger the difference to other countries. So I haven't seen any similar studies on drugs, but on ventilation I can say yes, that is the case.
Any other questions? Yeah, I'll take another two. Yeah, first you, and then, yeah.
Well, thank you. My name is Paranyu. I'm from Thailand, and I'm a student here. How much the problem about fraud, or maybe from DRG, is there any upcoding problems or any data distortion, and how it will be affected by the upcoming policy? Thank you.
Well, we have the medical review boards, so there's a service which is financed jointly by the whole system. They do individual assessments, for example, whether people qualify to get long-term care insurance benefits, but they also do institutional assessments, and they check the invoices of hospitals upon request of the sickness funds. Obviously, and so the ones which they do check, they find in more than 50% mistakes. I mean, it's not always obvious that it was deliberately, but I mean there is some evidence for yes, I mean the main effect is what they criticize is that hospitals keep patients for too long. It's less the upcoding per se. It's providing too many services. It's rather the opposite, you could say. It's providing too many services for the diagnoses you get, which then in Germany sometimes is upcoding, because the procedures also then mean that you get more money. It's not the diagnosis itself. The response or the response of the second previous government with Jens Spahn was that he was limiting the number of invoices which the sickness funds can pass to the medical review board. So this is now limited, so that the degree, the transparency has become weaker, so to say. So the hospitals were successful in getting their checkups reduced.
Final question. Yeah, please.
Maybe just a point of clarification. So you've taken us through this presentation about reforms and suggestions to address the SHI deficit, and it's kind of been taken on board, and the implementation period is maybe 6 years, maybe a bit longer than that. And now the question that they're trying to answer in 2026 is how to address the SHI deficit, which, how are they going to find 30 billion if they are still pushing out the solutions that have been suggested to them?
Well, maybe I wasn't clear enough then. I mean, I think we saw the hospital reform, for example, when it was set up, has nothing to do with the deficit. It started where I said that we have the feeling that we have too many inpatients, very variable quality, because patients can be treated in hospitals which are not technologically equipped for that. So the hospital reform has a different history. It would, on the other hand, if you think through, reduction of the number of inpatients would also save money, but it was not the primary objective. And I only wanted to say that it's surprising that people in the German policy arena don't put these two sides together, that there's many still pretend that the hospital reform, at least for the complex cases, is a good thing. But many states still think that the numbers of hospitalizations is okay, and obviously only that would bring up the savings. And all I wanted to say is, before you cut dental care, you should think whether 11 million inpatient stays wouldn't be enough if we currently have 17 million.
Okay, I'm afraid that's all the time we have for tonight. Please join me in thanking Reinhard for delivering a wonderful lecture and for joining us today. And thank you all for coming tonight. Thank you.
Thank you.